Worked really well till one time a fifth grader said, "Doctor, I see one liver's worse than the other, but it sure looks like both of them died." So I gave him an extra assignment. And, 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 and so the point being, though, if you don't get that transplant, you die. There are other conditions for which if you don't get the transplant, you die. In 1984, Congress created the Organ Procurement and Transplantation Network, or OPTN, a unique public-private partnership supported by hundreds of dedicated volunteers and experts. Last year, doctors in the U.S. performed more than 48,000 transplants, the most in a single year. In 2023, Congress passed the Securing the U.S. Organ Procurement and Transplantation Network Act, removing barriers in how the OPTN is managed, giving the Health Resources and Services Administration, HRSA, clear authority to improve the organ transplantation system in the U.S. For nearly 4 decades, OPTN was managed and run in its entirety by one single government contractor. But by breaking up the OPTN monopoly contract, we opened the door for more competition, transparency, accountability, and better results for patients. And it shows what happens when Congress drops partisan jerseys and works together to deliver a pro-patient, pro-family agenda for the American people. But I would argue there's more for Congress to do. There are over 100,000 patients waiting for a life-saving organ. We've heard reports of patient safety and dignity compromised and gross mishandling of organs, undermining public trust in the OPTN. Importantly, 13 people die daily waiting for a transplant. This committee has jurisdiction over the OPTN, and with that jurisdiction comes the responsibility to make sure the system is working as intended. And is there a way to cut down on a 100,000 person backlog off the waiting list? We should improve transparency, protect patient safety, and restore trust. There are 100,000 Americans waiting for that medical miracle called transplantation. We cannot fail them. President Trump's administration is making this a priority. We see this by them implementing tougher performance and accountability measures for organ procurement organizations, also called OPOs, and reduced financial barriers for living donors. I applaud the president's commitment to this issue and look forward to working closely with him on these efforts. I also appreciate Senator Grassley's long-standing leadership. Together, we've introduced the OPTN Fee Collection Authority Act to ensure responsible management of the fees that fund the OPTN. It increases transparency and encourages easy-to-implement common-sense improvements like automatic electronic referrals for donors. Senators Collins, Capito, Murray, and Baldwin, through their roles on the Appropriations Committee, have provided critical funding to modernize the OPTN. These efforts give Americans hope and a better chance that they will receive a life transplant. Again, pro-patient, pro-family, and making America healthy again. I look forward to today's discussion on how Congress can support the Trump administration, the OPTN, and the entire transplant community to better deliver for the American people. I will comment that obviously my ranking member was not here. And I think it's a shame he was unable to make time to attend today's hearing, considering approximately 13 people die on the transplant waiting list daily. It's also worth noting that the ranking member was given ample opportunity to engage on this hearing in a bipartisan fashion, but declined to do so. This is continuing a pattern of not working in good faith and prioritizing personal agenda over bipartisan discussions. But I will say, I am committed to working with every member of this committee to advance bipartisan solutions on issues as important as this. We've done so numerous times in the past and will continue to do so. With that, I'll introduce our first witness. We're joined today by Dr. John Magee, President of the Board of Directors of the Organ Procurement and Transplantation Network, or OPTN. He leads the body charged with overseeing and directing the OPTN, which is at a critical juncture and needs to regain the trust of families and patients. Dr. Magee has also held leadership roles with the National Kidney Foundation and the Organ Donation and Transplantation Alliance and the American Society of Transplant Surgeons and more. He's a transplant surgeon by training, attended the University of Pennsylvania and Jefferson Medical College. He completed general surgery residency at the University of Michigan, where he is a professor of transplant surgery. I look forward to hearing from you today. Thank you for joining us today, Dr. Magee.
Thank you, Chair Cassidy, Ranking Member Sanders, and members of the committee. Thank you for holding this hearing to examine the future of the U.S. Organ Procurement and Transplant Network, or the OPTN. In July of this year, I had the honor of being elected to serve as the president of the OPTN Board of Directors. I'm a transplant surgeon at the University of Michigan and I have over 25 years of experience in the field. I believe organ donation and transplantation exemplifies the best of healthcare in our country. The guiding principles are the respect for the life and dignity of donors and transplant candidates, and respect for the autonomy of donor heroes and their families. The OPTN was established by the National Organ Transplant Act in 1984, and it safeguards this sacred process. The OPTN is a unique private-public partnership with three distinct components. The OPTN board and the committees it oversees, our federal colleagues at HRSA, and the federal contractors that serve the OPTN. I am the president of the OPTN board, and members of the board and its committees include transplant professionals, organ donation specialists, patients, living donors, donor families, and community members. All are volunteers from across the United States. For the year ending in June 2024, the OPTN benefited from the expertise and lived experiences of 459 individual volunteers who served in 600 distinct positions. 600. That's more than the number of the House and Senate combined. A conservative estimate of the number of hours these volunteers contributed that year is 42,000 hours. All of our volunteers stepped forward because they care deeply about responsibly advancing donation and transplantation in our country. The OP10 has helped build a system that has saved over 1 million lives and has had substantial growth. In 2024, there were nearly 17,000 deceased donors in the United States. That represents a 98% increase in the last 10 years. There were also just over 41,000 recipients of deceased donor organs, a 73% increase over the last 10 years. And in 2024, 7,031 living donor heroes stepped forward to give the gift of life to someone in need. The incredible growth in donation and transplantation, along with advances in the field, have required the OPTN to modernize. Recognizing this challenge, in March of 2023, HRSA launched the OPTN Modernization Initiative. Congress acted to support the modernization of this public-private partnership by passing the Securing the U.S. Organ Procurement and Transplantation Network Act, which was signed into law in September of 2023. One of the first steps of the modernization initiative was to separate the OPTN board from the OPTN contractor. A new board support contract was awarded. Subsequently, an entirely new board was elected, and I'm the first president of this post-modernization era. Everyone who stepped forward to serve on the new board is focused on improvement. All embrace the principles of modernization, which include transparency, accountability, and robust oversight. Together, we are focused on ensuring the public can trust a system that has the capacity to save millions of lives into the future. We believe in the public-private partnership, and is why I stepped forward to take this responsibility. Another critical part of the modernization initiative is advancing patient safety, both for organ donors and for transplant recipients. The new OPTN board has made significant progress in advancing several key HRSA initiatives regarding donation after cardiac death and normothermic regional perfusion, which is a technique used after death to restore the flow of oxygenated blood to specific regions of the body. A new work group was also formed to address allocation out of sequence, which is defined as whenever a deceased donor organ is allocated outside the sequence of the OPTN designated match run. Other efforts are ongoing. The OPTN board is ready to engage in the next phase of the modernization, which will include integrating multiple contractors to better serve the functions within the OPTN. The OPTN board commends Congress and HRSA for its leadership, and we look forward to continuing to collaborate with you. True modernization is only possible through the convergence and collaboration of clinical experts, patients, living donors, donor families, our HRSA colleagues, and legislators. That is a public-private partnership. Thank you.
Thank you, sir. We're also joined today by Dr. Seth Karp, System Surgeon-in-Chief of Vanderbilt. He's also a professor of surgery, biomedical ethics and society, and anesthesiology. He regularly works with patients and performs liver transplantation for both adult and pediatric populations. He's held numerous leadership positions in organizations that are members of the OPTN or support the work. After graduating from honors from Harvard, he completed various residencies and fellowships before joining Vanderbilt's surgical faculty as director of the Transplant Center. Thank you, Dr. Karp.
Chairman Cassidy, Ranking Member Sanders, members of the committee. I'm grateful for the opportunity to testify about urgently needed reforms to the U.S. organ transplant system. My name is Seth Karp, and I'm a liver transplant surgeon, System Surgeon-in-Chief, and chair of the section of surgical sciences at Vanderbilt University Medical Center, where I served as the Transplant Center Director for 11 years. I practiced at one of the largest transplant centers and donor hospitals in the country, published research on the transplant system, and previously served on the board of the OPTN and UNOS. Congressional efforts on organ transplantation through legislation and oversight have begun to save lives. However, important work remains. As I testified to Congress in 2021, time is often a matter of life and death in transplantation, and time matters in the work that you are doing. Jill Chance, a 48-year-old woman waiting for a liver transplant at Vanderbilt so she can see her 4 grandchildren grow and meet her 5th who is on the way, understands this better than any of us. The fundamental problem is that in the past, contractors wielded monopoly control over the system, including policing its own members, collecting, analyzing, and reviewing data, and determining process and policy. Oversight was limited, and bad actors were shielded from accountability. Structural reforms are necessary. Expecting the system to police itself simply did not work. This conclusion is informed by history, experience, and data. I'll briefly describe 8 current problems and offer solutions. 1, ineffective oversight of the contractor. HRSA must exercise robust oversight of all OPTN contractors and subcontractors. To facilitate this, HRSA should directly collect member fees. 2, inadequate protection of donors. This is exemplified by the known performance and safety issues with the Miami and Kentucky OPOs. HHS should be
Dr.
directly...
Karp, can you speak just a little louder for these old ears?
Yes, sorry about that. HHS should be directly responsible for patient safety and receive complaints independent of the contractor. Number 3, insufficient oversight of OPO performance. Multiple studies demonstrate that there are many more organs in the system than are recovered for transplant. I applaud HRSA's proposed initiative for data collection regarding patients referred to OPOs. New CMS metrics must be enforced in the upcoming 2026 certification cycle, with failing OPOs replaced as appropriate. The pancreas loophole must be closed. 4, biased adoption of policy. Research by our group and others indicate recent OPTN policies led to increased organ discards, costing patients lives, and hundreds of millions of dollars of additional cost, much of it borne by Medicare. Too often, policy decisions at the OPTN have been determined by special interests. HRSA needs to be actively involved in and review major policy changes. 5, lack of access to data and methods. What cannot be measured cannot be fixed. In the past, OPTN members controlled critical data and methods and unnecessarily limited access to researchers. This may have allowed out-of-sequence allocation and errors in lung allocation, of which the committee is aware. This allowed sicker patients to be skipped on the waiting list. HHS must own transplant data and methods and make them broadly available. 6, the contractor has owned critical technology platforms. The U.S. Digital Service characterized the legacy contractor as hostile and threatening when asked to be more transparent and accountable. The government must own technology needed to run the system so failing contractors can be replaced without risk to the system. 7, lack of standardization of practice and implementation of new technology. There has never been a more exciting time for new approaches in transplantation. An example is donation after circulatory death, or DCD, which my colleague Dr. Magee just mentioned. Through technological advances, this method has saved thousands of lives. Unfortunately, lack of standardization led to confusion for both transplant professionals and the public. HRSA should take the lead in working with transplant experts to develop clear, sensible policy that ensures advances are quickly implemented across the system. 9, the transplant system has gotten too complex for a single contractor. More than 2 years after Congress recognized this in the Securing the U.S. OPTN Act, UNOS, the legacy contractor, is still responsible for logistics, technology, cybersecurity, policymaking, modeling, and finance. Each domain needs consideration of a separate contractor or subcontractor actively overseen by HRSA. Changes to the system must create a sustainable culture of accountability and performance. I urge Congress and the administration to act quickly. Time matters in transplantation.
Thank you. And I'll now defer to Senator Hassan to introduce the Democratic witness.
Well, thank you, Mr. Chair, and I'm pleased to introduce Anthony Wright, who is the Executive Director of Families USA, an advocacy group for healthcare consumers. Previously, Mr. Wright served as the Executive Director of Health Access California. And Mr. Wright, we look forward to your testimony.
Thank you, Chair Cassidy, Senator Hassan, and the committee. Appreciate the opportunity to testify. My name is Anthony Wright. I serve as the Executive Director of Families USA, the longtime national nonpartisan healthcare consumer advocacy organization. We really appreciate this inquiry into our nation's organ transplant system, and we urge policymakers to prioritize and protect organ transplant patients by improving transparency and accountability, access and affordability, and ensuring better ethics, efficiency, and outcomes. As a patient advocate, I first became aware of the many issues with our organ transplant system 2 decades ago, when a friend and colleague, Robert Phillips, was on dialysis for 5 years waiting for a kidney until finally getting a donation from his now wife. Even as a savvy board chair of my health advocacy nonprofit, he faced waits and inequities facing many Black organ transplant patients. Black Americans are 3 times more likely to suffer kidney failure than others, but are underrepresented on transplant wait lists and often receive lower quality organs. Robert's new kidney has worked great for 20 years, but now he's back on the transplant list as a replacement and facing many of these same issues today. Over 100,000 patients languish on waiting lists, yet 11,000 viable organs were wasted in 2023 alone. Over a dozen Americans a day await transplants and die every day awaiting transplants. Congressional investigations and media reports have revealed fraud and abuse, including line skipping, safety violations, and unethical procurement practices. Reforms are needed to bolster the public trust, including for the millions like me that volunteer to be an organ donor, and which is foundational for the very viability of our organ procurement system. So as such, Families USA has supported bipartisan organ procurement reforms in the last several years and seeks action administratively and legislatively. Recognizing that the industry is not inclined or equipped to oversee itself, we urge HHS to use its full authority under existing law to 1, remove industry conflicts of interest from network governance, 2, to break up the existing monopoly contractor, and 3, to take actions to decertify failing OPOs like was just done in South Florida. Furthermore, Congress should address misaligned Medicare incentives that lead to unethical procurement practices, including the aggressive collection of non-viable organs to rack up reimbursements. This is an extreme example of the billing abuses that Senator Cassidy, Senator Sanders, and others have rightly proposed to reform in Medicare Advantage and elsewhere. Such reforms can and should be part of a broader package of quality and affordability agenda, especially since successful kidney transplants save significant money compared to the expensive dialysis treatments. Congress must also address healthcare costs and coverage broadly, especially to do right by organ transplant patients. Without continuous and comprehensive coverage, patients paying for these many medical treatments that are needed would face financial ruin. And in many cases, insurance coverage status is a key factor determining whether patients can even be listed for transplants in the first place, let alone their ability to access, afford, and adhere to follow-up care and medication instructions for maintaining a healthy organ. So keeping Americans covered is why today's vote in the Senate to extend the enhanced premium tax credits is so urgent, both to protect current and prospective organ transplant patients and all of the 22 million Americans facing massive premium spikes in just a few weeks. Congress must immediately extend these tax credits to prevent premiums from more than doubling, often by thousands of dollars, and to prevent 4 million from fully falling off of coverage. Any policy proposals beyond the clean extension should be vetted through the lens of an organ transplant patient or any patient with chronic conditions who, for example, would feel the full financial shock of shifting into a higher deductible health plan, or who would be harmed by the return of plans that deny or discriminate based on pre-existing conditions. That's the concern of Paul Gibbs of Utah, a small business owner, husband, and father of two, born with a serious condition for both kidneys. Paul was told he needed a kidney transplant when he was uninsured as an adult. And it was only after years of haggling with providers and insurers that he was able to get his transplant covered by Medicaid and Medicare. But for the rest of his life, Paul must take expensive daily medications to keep his body from rejecting the donated kidney. He credits the ACA in allowing him to live and to get the coverage despite pre-existing conditions. And his story shows there's no replacement for continuous and comprehensive coverage, and that's especially true for organ transplant recipients. So in closing, we urge the Senate to prioritize the needs of patients like Paul, Robert, and countless others. That means ensuring access and affordability broadly and moving forward with the meaningful reforms of our organ transplant system. Thank you.
Everyone, that today's hearing is about examining the future of the OPTN to improve patients' access to organs. Members and witnesses are encouraged to focus their discussion on this important topic. Senator Marshall.
Thank you, Chairman, and welcome to our our witnesses. My first question for Dr. Magee: how does the current oversight structure ensure that the organ procurement and transplantation network meets performance and patient standards?
So the OPTN is a public-private partnership with HRSA, and we look at making sure we're adherent to the principles underlined in NOTA, the final rule. We look at data regarding our outcomes, and the OPTN is also a small segment of this entire process that we're talking about. So we monitor policy, adherence to policy, and look for signals in those regards. So it's really based on our policy that we follow to make sure we're doing what is both in regulation and what we're responsible for.
Thank you. Let's go to Dr. Karp. You talked about ways HRSA can encourage innovation. Can you elaborate a little bit more on this, that how the innovation would benefit patients?
Yeah, thank you. So this is the most exciting time in my lifetime in transplantation. It's really quite amazing what's going on. As these great advances come across the network and come across all of transplants for it to benefit the patients, there really needs to be centralized approaches to these. And I think donation after circulatory determination of death is a great example of that. So this is a new technology. We've been doing organs like this for a long time, but the new technology has been over the last 5 years, has really revolutionized transplantation. It's saved thousands of lives. At the moment, the technology, however, is being put out, and if it kind of each center has their own approach to this technology. And for us at Vanderbilt, we became the largest heart transplant center in the country because of use of this technology. But other groups around the country have not adopted the technology as quickly. And what I'd really like to see is a central mechanism by where when a new technology is brought forward, it's found to be useful, then it gets disseminated much more quickly across the network with a central oversight from HRSA as opposed to the way it's done now. And HRSA needs to take a much more active role in disseminating that technology.
Okay, thank you. Let's go back to Dr. Magee. Dr. Magee, the Midwest, where I'm from in Kansas, is famous that we have a higher organ donor rate than some the coasts do typically. And there's concern that too many of our organs are leaving the Midwest. What is the current policy on the location of the harvested organ versus the location where it's going to be used?
So certainly, so the OPTN in the past, when transplantation started, 40 years ago, the confines of ischemic time, or how long the organ can be outside the body, limited a lot of it, and the sharing was much more local. As the methods have improved, we can both share more broadly and make things more fair across the country.
What do you mean by more fair? What does that mean?
Meaning standardizing waiting times, making sure that sicker
So
people
so
don't
you're
die.
saying that more fair is to take organs from Kansas and transport them to some other state that's not doing a good a job about their encouraging donation?
No, I'm not saying that. I'm saying that if one of the principles of NOTA is that medical urgency should take place, a second principle, medical urgency should be a priority. Second is geographic boundaries, to the extent possible, should not be a limiting factor. So our goal is really to increase and as you're pointing out, the rate of donation is also important to know, which is a tough thing to determine. We're looking into that, as is the community, and making sure that we optimize the system as much as possible.
So that doesn't really sound fair to me. Dr. Karp, can you shed any light on your thoughts on, I mean, how do we're encouraging people to donate their organs, but frankly, they'd like them to stay locally when possible?
Yeah, so I agree with what you're saying. The major policy changes over the last few years have, in fact, moved organs from lower resource communities into higher resource communities. So places in the deep south, places in rural areas, they tend to overall have a net export of organs now with the new policy changes. I think that's very, very difficult to justify. In addition to that, with these new policy changes around broader sharing, what's happened is that we have more organ discards, and I've published about that. Other people have published about that, and it's dramatically increased costs. A liver can't save more than one life. And so this idea that somehow by moving this liver around the country or moving this organ around the country, that you're saving more people's lives is simply not true. And this is an area where I think the policy has been hijacked by special interests. And I think this is something that HRSA needs more oversight on. It's a complicated situation. I'm not going to tell you that I know exactly how this needs to end, but it is something that I believe has been put forward by and passed by special interests.
Thank you so much, panel. Chairman, I yield back.
Yeah, I agree with that. Auctioner in New Orleans is one of the largest centers because the South does such a good job of donating organs. And then it's set up that, all of a sudden the organs harvested in the South are going elsewhere to places with a much larger population, but which do a much weaker job of actually harvesting. And so I agree with the special interests seem to have kind of overridden that, which is, if you see where I'm going with that. By the way, I really enjoyed your technology, your conversation. Dr. Karp, if we have technology out there, the reason you go to the American Association for the Study of Liver Disease or something similar is to learn about the new technology and to adopt. But what you're telling me is that there's an inertia that people are not adopting technology, which presumably gives you a better outcome. Now, that's not medicine at its best. What is the obstacle there?
I think the point's very, very well said. What we do, as we all know, is life and death, and we get comfortable with doing what we're doing. And so to do something differently is a risk. And for all of us, we need to think about the risk of doing what we're doing versus the risk of not adopting new technology. And I feel that if there was a central oversight that said to the whole community, that says to all of the people that work in transplant, hey, we've got a really good technology here. We've looked at it. It looks like it should work, and it looks like it should work.
But let me interrupt, because it does seem that if you look at transplant survival rates and time on the waiting list, that those statistics almost would give you a market force towards those places that were adopting the more efficacious technology.
No doubt, and that does happen. My concern is that it happens too slowly.
So how can we speed that up? And I guess that's what this hearing's about.
Yeah, but by having HRSA take a broader role, and for example, for the
but let me ask you, because if you're saying HRSA should dictate, the Ronald Reagan quote comes to mind. I'm here from the government. I'm here to help you. Now, sometimes it's actually true. After Katrina, we were very glad to see FEMA there. But that said, we also know that if you start dictating from on high, you may go down a cul-de-sac, as opposed to turns out we have better results over there. So how do we avoid that? Yeah, so I'm not saying that HRSA should dictate what organs groups use. That's not been part of our policy, and I don't think that it should ever be part of our policy. But for HRSA to say to the community, we have a new technology, we believe it works, and we're going to educate you on how to use this technology. We're going to provide resources for you to improve your use. Being a group of people, maybe even highlight it more. Exactly. Okay. Have a central mechanism. Dr. Magee, from Mr. Wright, we heard that there is over-harvesting, and he suggested that sometimes people harvest organs which are not viable in order to get remuneration. Dr. Karp spoke about organs that should be harvested that are not or otherwise wasted. Can you square that for me?
Certainly. So a good principle here is to respect the autonomy of the donor and their desire to donate. That is what the principal mission of the organ procurement organizations is to do. So they make every effort to try and make sure that wish is carried out. The donors, as you mentioned, market forces could be a factor. It's also what is viable and what is not viable. As Dr. Karp mentioned, there's a great deal of variability of practice across the United States. And that can both be, we can make efforts to standardize that, but at times you can't dictate the interaction of a patient and a physician. And if a program or a place that doesn't have the technology to do something needs to be brought along with that process rather than a simple mandate. So I agree with the points that are made, but I think it's really the process. And as you've pointed out, it's really about the education part of things.
I'm a little rusty on this, but I know that some transplant centers will take an organ that other transplant centers will reject.
100%.
That actually seems like that could be more standardized, unless you're telling me that some with higher volume and greater expertise are able to successfully transplant an organ that another could not.
That is a component of things, certainly. And we don't want to, there's also the recipient in this or the candidate. So sometimes people can, because of how sick they are, they might need a better organ, and other patients may be able to manage with an organ that is a very good kidney, but not perfect. So I think the other part of this is the pressure on this has made, has brought everyone forward. So I think people have learned a lot. When I finished my fellowship along with Dr. Karp, there are organs now, over half the organs we use now, we were told basically could never be used. So that's progress, and it's bringing everyone forward.
Dr. Karp, you're both, I'm sorry. Dr. Karp, you're both an ethicist and a surgeon. There's a friend of mine, Jeff Wright, a cardiologist in Shreveport, Louisiana, who thinks deeply about these issues. You mentioned DCT. DCT, tell me again what that is.
DCD, that's donation after cardiac death.
Now, let me just read what he's concerned about. That a person declared dead by the legal standard of irreversible cessation of circulatory function is having their heart restarted. So there seems to be a little bit of an ethical concern about that. Someone is dead, you restart their heart merely to procure the organ to transplant. And so, not brain dead, but heart restarted. How do you address that ethical issue?
Yeah. So whenever we do a transplant, the heart from the donor stopped, and then we restart it. So the fact of restarting a heart is something that we've been doing since heart transplantation started. That fact in and of itself, I think, is just something that we know that happens. When we talk about the donor being dead, there are very careful safeguards around this process. So there are two ways that you can be considered dead: from brain death, and there's basically no brain function. This is how it's generally done, or in the past had been done for organ donation. But more recently, we have this technique called donation after cardiac death. In that case, the patient has basically an irreversible neurologic event. They are allowed to die naturally. The heart stops, and then there's a waiting period of 5 minutes. After that waiting period occurs, then the heart can be, the heart, we can put catheters in and get that heart to start again. But as we do that, we block all blood flow to the brain. And so the possibility of any kind of consciousness is basically is actually eliminated.
I don't mean to be cheeky here, but somebody once said the purpose of embalming is to make sure the person's deceased. Now, in the sense that if you are basically infarcting the brain to induce neurologic death, Dr. Magee, you shook your head no. Is that am I not understanding this? Because it's an ethical conundrum that people are concerned about.
Sorry.
No, please.
I also didn't mean to interrupt. And you're right that that's kind of an absolute marker of death. In the United States, brain death counts and cessation of the heart that is not going to be restarted is another marker. As Dr. Karp mentioned, the goal is to restart the heart. It's just a matter of location. So the key in donation after cardiac death is to make sure they've had cessation of respiratory and cardiac function. The other part of this is in some DCD donors, there's a technique used to reperfuse the blood inside the body, which the key there is to make sure that we do not establish blood flow to the brain. And there are both techniques to that. And in fact, actually, the OPTN in November issued guidance around the best practices of that, which was a clarifying statement. So I appreciate the points, but.
So the guidance from the OPTN is to clarify the possible moral conundrum.
The guidance from the OPTN is to clarify the potential reperfusion of the brain and the upper circulation. The moral conundrum has been discussed for a long time. As Dr. Karp has pointed out, donation after cardiac death and even normothermic regional perfusion has been in the field for 20 years. I published a paper at least 15 years ago on that. So there's been a lot of discussion, and we just need to continue people and engage in honest, open discussion about the ethics of it.
Dr. Karp.
Yeah, and so I would say that the analogy of your embalming is that this is the 5-minute waiting period. So after the heart stops, we wait a period of 5 minutes, and the data suggests that there has been no person in human history that has ever reanimated by themselves after this waiting period. And so that's why we've adopted that 5-minute waiting period to basically assure that the declaration of death is correct, and then the organs are procured.
Senator Moody.
Thank you, Senator Cassidy, and thank you so much for holding this hearing, and to our witnesses for being here today. Over 30 years ago, a baby named Charlotte was born in Virginia. Charlotte was born with a lot of energy, an infectious smile, and a heart defect. Charlotte has Down syndrome. And as we know, those with Down syndrome are more likely to suffer from congenital heart and kidney problems. By 10 years old, Charlotte had 4 open heart surgeries. And by 22, she needed a full heart transplant. Despite some worries, Charlotte found a match, underwent a successful transplant, and has had a successful life since. Fast forward to 2021. A beautiful baby named Zion Sarmiento was born in Ocala, Florida, my home state. Like Charlotte, baby Zion was born with Down syndrome and had a heart defect. But after 40 days in the NICU, Zion passed away after being denied a heart transplant. Baby Zion was only 16 weeks old. The story of baby Zion reminds us that no matter what advancements we make in healthcare, there are still structural barriers that exist, and those barriers hold back that healthcare progress for some. The National Down Syndrome Society reports that only 52% of people with disabilities who asked for a referral to an organ transplant specialist actually received a referral. Additionally, almost half, 43% of pediatric transplant centers see intellectual disabilities as a factor against transplant due to assumptions about quality of life. Close to 2/3 of transplant centers have serious reservations with providing a kidney to those with even mild intellectual disabilities. People with intellectual disabilities are beloved members of our communities, so very valued. And they shouldn't be discriminated against for something as vital as an organ transplant. Today, Charlotte is with us in the room. She is beloved. She is an inspiration to so many, not only in her family, but across our country. It is she's the person that bears the name of a bill that I lead in the Senate with Senator Magee Hassan. Our bill is bipartisan. It passed the House unanimously just last year, and we'll keep on fighting for this bill that is going to be so important to so many who will come after Charlotte. And my commitment to baby Zion and Charlotte and the rest of my constituents in Florida is to convince our Congress to waste no more time to get this bill across the finish line. I fully believe we can get it to President Trump's desk next year. I have a few questions for Dr. Karp. Dr. Karp, I understand that you helped a man with Down syndrome get an organ transplant. And to the extent you are able, within the confines of the law, to share, would you tell us a little bit about that man and his story?
I would love to do that, and he and the family have given me permission to talk about him. His name is Joe Idle. He's in his mid-30s, and he received a combined heart and liver transplant at Vanderbilt. He is a man with Down syndrome and multiple other medical problems. He is absolutely thriving. I get pictures of him with the Philadelphia Eagles, especially after they won the championship, and just provides so much joy to our team and to his family, and is living just a wonderful life. And I strongly, strongly support the Charlotte Woodard Organ Transplant Discrimination Prevention Act, and I'm grateful that you put it forward.
Would you say even one case of organ transplant discrimination against a person with Down syndrome is too much?
I would. I think we have to be careful to understand that some of these patients are very, very complicated, and there's some of them. Some patients might not make it through the operation because of other things that are associated with disabilities. And we have to be very careful about that. But in patients that we think have a good chance of making it through the operation, it's absolutely, there should not be discrimination against those patients whatsoever.
And does your hospital have a non-discrimination policy that explicitly covers transplant evaluation?
We do.
And how does Vanderbilt ensure clinicians follow it?
So we have a very well-developed transplant center. We have transplant center administration. We talk about these things often. These patients come before our committees on a regular basis, and and everybody knows the policies.
Thank you so much. I've met my time limit. And Chairman Cassidy, I appreciate you calling this hearing and hope that we'll be able to consider this incredibly important bill to so many people across the country.
Senator Moody, and now Senator Kane.
Thank you, Mr. Chair, and thanks to all the witnesses. I'm going to get to organ transplants in a minute, but I cannot resist, with 3 liver doctors in the room, to ask a question about hepatitis B vaccination. Last week, the Advisory Committee on Immunization Practices, ACIP, voted to end a decades-long recommendation to vaccinate all newborns against Hep B at birth. Hep B is a highly infectious virus that leads to chronic long-term illness and can cause severe liver damage and cancer. In September, this committee held a hearing with Dr. Menars and Dr. Houry, departed public officials from the CDC. And during that hearing, Chair Cassidy used his time to discuss the importance of Hep B vaccine, sharing his own personal experiences treating patients with hepatitis as a liver doctor. To repeat some of the facts from that hearing, the chairman said before 1991, as many as 20,000 babies were infected with Hep B in the United States. He also shared while that Hep B vaccine is recommended at birth, it's not mandated. Finally, he said now fewer than 20 babies per year get Hep B from their mother. If a child is infected with Hep B at birth, over 90% of them will live with the consequence of a lifelong infection. Now, we often know a mom's Hep B status before birth. Some have asked, why would we vaccinate a child if we know the mother's status? But even if a mother tests negative during pregnancy, it's still recommended to vaccinate the infant because Hep B is highly contagious and can be transmitted through contact with even a minor amount of blood, for example, on medical equipment. Without widespread vaccination against Hep B, numbers will begin to rise again. So a rise in infection among infants will ultimately lead to a rise in chronic liver disease, place even more burden on our already strained healthcare system and organ transplant network, adding to the current 10,000 people awaiting a liver donation currently. Dr. Magee and Dr. Karp, you're both practicing transplant surgeons. Could you describe for the committee what would happen if we stop vaccinating infants against hepatitis B, and what would the long-term impact of that be on the transplant network?
So certainly more, as somebody that does pediatric liver and kidney transplants, seeing anyone develop a disease that we had previously not had to deal with would break my heart. The OPTN, in my capacity as board president, has no requirement about vaccinations going into it for many reasons, including the issues that are very complex. But Chair Cassidy mentioned walking around with a normal liver and a sick liver. It is pretty simple to understand that this causes a problem. So I agree with all your comments.
So no requirement, but a recommendation about best practice.
Well, we don't even make a recommendation in that capacity, but our center would recommend that.
We concur. Thank you. Dr. Karp.
Yeah, so I'm not, to be clear, I'm not an expert in infant vaccination, but what I can tell you is that having done this for 30 years, when I first started doing liver transplants, there were an enormous number of patients that had hepatitis B as a cause of their liver disease, and many donors that had hepatitis B, and those donors were not as usable because of the hepatitis B. That is almost completely gone, and boy, I would hate to see that change.
And that is gone. You believe the prevalence of vaccination is one of the reasons why that's gone down so significantly.
That is my belief.
Yes, thank you for that. During my time as governor, I supported the development of the Virginia Biotech Research Park in Richmond, and I encourage UNOS to move to the city into that park, and it still operates today. It's operated for over 40 years. It's historically played a critical role in our transplant network, and yet I have read concerning stories about failures to protect patients. While Congress has taken some action, more needs to be done, and that's across the spectrum. With over 100,000 people currently on organ transplant waiting list, I'm encouraged by today's hearing. So let me ask just a general question for each of you. Given where we are today, what do you feel is the single most important policy that Congress can enact to further improve our transplant system? And if I could start with you, Dr. Magee.
I think preserving the private public partnership that has built this system. There are both the experts who do this that are a self-renewing resource, would hold each other accountable. Ideally, we need to make sure that happens, and the partnership with the federal government to make things happen, in addition to oversight like this. So I think maintaining that is probably the best thing that can be done and maturing things. I also think, to Dr. Karp's point, which I also agree with, is making sure that everyone has ready access to the data. That data, no matter where it sits, needs to be accessible by all and allowed to be published and discussed in open forums.
Dr. Karp.
I think to improve the system, what we're really talking about is getting more organs. And each limb of the system has had extremely good oversight, except for the OPOs. The transplant centers have had the oversight of the transplant centers has been quite good, I think. But the OPOs have not had that. And that change will, I believe, potentially provide enough organs for every patient that dies waiting for a heart, a lung, or a liver, and make an enormous impact in the 100,000 patients that are waiting for a kidney transplant.
Great. Thanks, Dr. Karp. Mr. Wright.
The most urgent thing is the vote on keeping people covered, but on the organ transplantation system, it's accountability. The industry should not be expected to police itself. And so whether it is the oversight over the OPOs and going beyond just South Florida to other places where they're failing, or breaking up the monopoly contract, or just changing industry conflict of interest in the governance.
Thank you. I have another question, but I'm over time. Senator Warnkowski.
Thank you. And I appreciate what you have raised, Senator Kane, about the hepatitis B and the response that we have seen. Alaska has quite an interesting history and story. Among our Alaska Native population, we were seeing some of the highest rates of hepatitis B some decades ago. And we were really targeted as a pilot project to see if we couldn't reduce these rates with an emphasis on the vaccine, because what was happening was young people coming down with these cancers, particularly kidney, liver, the organ diseases, and we have virtually wiped that out. And we see such extraordinary success. I agree with you. We don't want to return to that period in time. So I appreciate what was shared just now. I want to direct my questions to you, Dr. Magee, initially here. I come from a state where it's big, wide open spaces. We are geographically disadvantaged in so many ways. But it's not just Alaska, it's other remote and rural areas where people face longer travel times. There are fewer transplant centers. We don't have We don't have a center in the whole state of Alaska. We have more limited access to specialty care. But I hear from people in Alaska that the wait for an organ transplant is not only long, sometimes it's almost impossible, which is very discouraging. So I'd like to hear how you feel the OPTN is working to ensure that allocation policies appropriately account for some of these geographic barriers, so that we don't have a situation where you literally have to be in the big city around medical hospitals in order to be a recipient of an organ donation, that we're not leaving our rural and our remote folks behind.
Thank you, Senator Murkowski. There's almost no state that does not have an area that is under resourced, no matter what state you're talking about. So in Alaska, I appreciate it's more difficult. Within the bounds of the OPTN, we cannot establish a hospital in Alaska. That would have to happen by lots of things, but we're looking at access to care. Traditionally, the OPTN had only really had the from the time the patient came in and was listed. So we're actually looking at referral data, like when do people get referred, and even earlier than that, to look to see what are the barriers there. Anytime we do anything, we also look at impact on rural centers as well, and then. So those are the two main things that can be done within the confines of the OPTN.
So let me ask how you are doing when it comes to overall communication with patients, because again, this is one of the concerns that we hear, that patient-centered reforms based on the input from patients themselves has perhaps in the past not been the best. And I know we've got some new policies, some new programs that OPTN has put in place to improve the communications with patients, with the candidates, with the donor families, the whole network there, including the waitlist status changes, the organ offer notifications, donor family outreach. How can you share with me how you are making this information more readily, easily, accessibly available to the patients?
Certainly, as you know, communication is always a challenge, even within the OPTN. There are multiple sources of information, but within the OPTN, recently, the central access point, if you will, to the physician and the information has been centralized to one website, and there's a patient-centered design going on in that. And so the goal would really be to not create 3 or 4 websites that or sources of information that all reflect the efforts of the entire network. So there are contractor websites, there's the OPTN website, and so we're working on standardizing that. We also look at patient focus. All of us that are physicians know how the importance of being able to communicate with a patient at their level and give them as much information as they need. So the information is being centralized and made sure to be compliant with patient level.
So do you feel that the current board then is doing a good job in ensuring that patient and donor voices are heard? I mean, you've shared how you're communicating outward, but are you also confident that you have the capacity to be receiving that information from the patients themselves?
That's a great question because, and no, I'm not entirely confident we have that under control, just as the board and the OPTN committees are only representatives of part of the community. My goal has been to really increase that community input. So I think there's the opportunity to partner within the OPTN, there are patient advisory committees, which is one form, but that isn't always representative of the whole country. So my goal would be to come up with approaches to hearing from experts, whether they be in transplantation or the patient experience. So organizations like the National Kidney Foundation, other things that are larger patient focusing, including even just the general population, because donors are another group of people that we do not,
right.
What does the American citizen want?
Mhm. I have no further questions. Senator Kane, did you have anything you wanted to add?
I would ask one additional question to Mr. Wright, if I could. In your written and oral testimony, you note there are, quote, rampant disparities in the transplant system, particularly for Black Americans, as well as other inequities based on ethnicity, income, and insurance status. There was a story in the Washington Post in September that outlined bias in the transplant system that I'd like to be introduced into the record without objection.
Without objection.
And that story documented bias in stories of organs intended for lower income patients being declined and later transplanted into patients at a more affluent hospital. Very concerned about this. And I'm worried that minority communities, people with disabilities, others who are underserved, who already face an uphill battle in accessing care, aren't getting equal access to transplant. So talk a little bit about the types of disparities that exist and what might we address them.
Thank you for the question, Senator. Obviously, there are inequities throughout our healthcare system, and the organ transplant and procurement system rests on top of that, and in some cases, exacerbates them. The issues of socioeconomic status, including your insurance coverage status, issues of poverty or low income, those obviously have a real impact. Again, even the ability to get on the list because of your status. It makes sense for some cases that you need to have if you need to get a transplant, you want to have adherence, but adherence coverage matters, financial barriers matter to that. There's also, but even if you hold for that, there's still racial and other disparities. And so that suggests implicit bias or other things, both in the healthcare system that feeds into the lists in the transplant system and in the system themselves. There was issues about even the criteria and race-based things in the criteria with regard to that. And then I would also just say that there's just a question of transparency and of leadership and of accountability. The work of when there is abuses like in that Washington Post article and in other media reports, the communities that are hit the hardest by those abuses are typically low-income communities of color, et cetera. When you have investigations of and whistleblowers talking, they talk about how the direction is to target Spanish-speaking or non-English speaking communities, for example, communities where they can maybe get away with it more. And so I think that there's a need to crack down on whether it's OPOs or others that are failing. And if you do that, you will have a big impact on equity. And then on the positive side, leadership matters. When the OPO in San Francisco had one of the first African-American CEOs of an OPO, they were able to partner with the community and have dramatic increases in organ donation and transplantation for both African-American, Hispanic, and Asian populations by 50, 70, 90% increases. So leadership matters, accountability matters, and that's my answer.
Senator, could I take 2 more minutes and just tell a story? It's just really a story for all of us. Some people will get nervous about the word equity, but I learned a really good equity lesson at the beginning of COVID when the vaccine was first developed. You'll remember that in the fall of 2021, with a limited supply of vaccine, we decided we had enough to vaccinate people over age 65. And so that was kind of aside from healthcare workers, the over 65 cohort was the first cohort available. Talk about a rule that is pure equality. You can get it if you're over age 65. But what I noticed in my neighborhood is because it was still short in supply, there were people who were over age 65 who could spend time on their computer researching which CVS had it and which Walgreens had it, and then they could drive to that one to get it. And there were a whole lot of people who either didn't have a car or they didn't have a whole lot of free time to do that research who couldn't drive to get it. And so what we found a few months into this was a rule that was complete equality. You can get it if you're over age 65. The actual result was that the most affected communities, those that were getting COVID at the highest rates and those who were suffering the most serious consequences to COVID, were usually much less successful in actually accessing the vaccine than others. And so we had a rule that was equal, but because we didn't also build in a little bit of an equity component, it wasn't that effective. I think effectiveness should be the key. And we had a rule that was equal but not equitable, and hence it wasn't effective. We ended up, making some different decisions, uniformly in a bipartisan way, Congress and the administration. Take vaccines to targeted populations that are most at risk, whether they're, frontline workers or senior centers because of people's age and health condition, they could be most at risk. Go into public housing communities where people might not have transportation. And so equity is not something that should make everybody nervous. We ought to be asking questions about effectiveness, and sometimes rules that are purely equal end up with results that actually aren't that effective. And so I appreciate, Mr. Wright, you talking about ways we could make this system or healthcare generally more effective by focusing a little bit on the equity side. Thank you. And I'm finished and yield back.
Appreciate the story, Senator Kane. And as I'm thinking about some of the Alaska COVID stories, it was about access. If you're in a small remote village and you're basically you're afraid to travel out to the city because you may be in fear of travel because you haven't been able to receive a vaccine. So we literally had to send individuals to fly into these very remote communities in the dead of winter, try to figure out how to keep the vaccine from freezing, put it literally under your armpit, under your parka as you're driving your snow machine out, giving people vaccines in the back of a, it wasn't a Super Cub, it was a little bit bigger, maybe it was a Caravan. But it was about access. And so when you don't have access, equality and equitable treatment doesn't really mean much. So whether it's getting transportation, if you're here, if you're in Baltimore, or if you are in Buckland, we got some challenges. Thank you for sharing that. And if there are any senators that are going to be asking additional questions, they will be able to provide questions for the record through Monday, January 5th, due at 5 o'clock. But thank you to the witnesses for appearing before the committee today and for your contributions in this space. And with that, the committee stands adjourned.